So fantastic. So I think we are going to go ahead and get started. While other people join, we're going to go ahead and get started. Welcome to everyone. I am Wirungwa. I am the one of the directors of the Global Health Catalyst, really launched at Harvard and now has been supported by the NIH to extend to other institutions with the focus of catalyzing collaborations that can address disparities in the US and globally. We have a fantastic session ahead of us today on London Global Cancer Week. It's the first time we're going to be participating. And so we really appreciate the invitation from Dr. Susie Stanway, Mark Lodge, Dr. David Collingridge, Dr. Eduardo Kazab, who is on with us, and Miriam Motebi and other people. For today, the theme of our session is going to be on the Cancer Moonshot 2.0, win-win collaborations to close the cancer divide. And really, when US President Joe Biden and Dr. Joe Biden started the Cancer Moonshot last year, reignited that, the Lancet called that Cancer Moonshot 2.0, partly because this was a kind of revamp of what President Obama has started in 2016. And the Cancer Moonshot sets really ambitious but achievable goals. And there are really two. One of them is to reduce the death rate from cancer by at least 50% over the next 25 years. And the second one is to improve the experience of people and families living with and surviving cancer. Ultimately, the goal is to end cancer as we know it today. And I think London Cancer Week provides a tremendous platform for us to think about how we can collaborate to do this. Actually, when the United States president launched this, he called on everyone to do their part. And while the immediate goals were domestic to the United States, part of the engagement has led to the commitment to extend this globally. And so this is actually important because, as we know, low and middle income countries have about 80% of the global cancer deaths. And so it's really important to think about how we can do collaborations to extend the cancer moonshot globally. Now, when we say collaborations, one of the key things, if you come into the Global Health Catalyst Summits, one of the key things you hear is that these collaborations have to be win-win. And win-win collaborations are really important. And I think one of the people who, potentially you can trademark that win-win too is Professor Ahmed El-Zawawi, who is on with us today. And so before we introduce our key speakers, I'm going to give him a chance to tell us a little bit about what win-win means. Professor Ahmed?
Hello. 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 Would you kindly share the screen?
You have the permissions.
Okay. Yes. Really, I am honored to be among you today. And to tell you on behalf of all of us, I am just a modest person among all these leaders and faculty of Win-Win Initiative, to tell you warmest welcome and hello. And please, we need every collaboration to fight the big challenge of affordability of better value cancer care and control in the real world. The win-win movement aims at the increase of affordability of better value cancer care for millions of underserved cancer patients in the world, in rich countries and low middle income countries. This is very important thing. This is global, via scientific approaches and within win-win scenario, because this is the only approach that in which we can succeed in the upcoming year. Win-win collaboration. Is that feasible? Yes, there are already tens of published scientific serious examples to reduce enormously the total cost of cancer care without compromising the outcome on patient and even to get better value cancer care. Yes, this is our websites and publication and all. And I don't claim that it's mine. This is coming from inspired from my work and my discussion and the idea of many colleagues in the world. Along the last 3 decades, we have to admit this, and still that, and despite of many conferences, report, classic publication, commission, agendas, program, and all these things and declaration, the gap between the required cancer care and the available was widened in the last 2 decades. This is published. Many publications about this. There is no convincing evidence that the needs wouldn't be increased in the 3rd decade of the 21st century. It's known that the shortage is maybe tragic in some part of low middle income country, maybe is some shortage in some others, but there are some unserved patients in affluent countries too. According to American Society of Clinical Oncology, 40% of American citizens, the first cause of fear of cancer is the financial burden. You imagine this, 40%. And the risk of pancreopathy. In ESTRO, European Society of Radiation Oncology, 1/4 of cancer patients in Europe, in West Europe, didn't get the indicated radiotherapy. So it is global. But the more tragic really in low-middle income countries and some part of Sub-Saharan Africa. The proposal of cancer fund is key for solution, could help, but is not the magic sole solution. We should think about that. Many published evidence that how to reduce, and we publish this, and you can find it in our. This is by many authors. It is not. We are not the author, but we are the author of these books and publication presentation. That the cost of $100,000 of certain cancer drugs to be only could be reduced to $4,000 to $6,000 in some without compromising the outcome. You imagine this. All this is published. And some other drugs to reduce the cost from scientific way by 70 to 80%. So you imagine how it is, whatever the fund cannot cover all these things. Moreover, we see the scientific misleading points about doses of some immunotherapy of cancer and drugs, even approved by FDA, as is published and published by FDA and published other. All without compromising the outcome, and even in some cases to get better value. Many examples, tens of examples in our books and our publication. It's free, please visit them. There are many shocking examples of waste. You imagine that the waste of leftover in vials, in some expensive drugs is estimated to be $3 billion per year. What is how you can collect the fund? By the way, $3 billion is more than the sale of all devices of variant Siemens last year. Are the in the world all their sales? Are there solutions to reduce enormously this waste? Yes, it is published. It is published. But who listen? This is my question. Who listen? Instead of repeated talks about lack of radiotherapy in many parts of the world and many other, but there are ways unpublished to double or even triple the number of patients with the existed present facilities. Yes, now you can do it. You can do it even last year, before it, but nobody listed. Also, it could pave the way to open markets for the needed from 10,000 or even more of radiotherapy and clinical oncology service in the world. This published. You can see reference here and you can read it. It is a big miss to say that Africa has limited resources. If it has limited resources, it will not be colonized. Okay, it has the curse of having rich resources, but how to use these resources? Is the solution to send some fund as begging or charity from each country to Africa or other low middle income countries? No. It should be well scientifically planned, transparent, win-win approaches. Every US dollar should have its positive return on both taxpayer in rich countries and citizen in low-middle income countries. And for the progress of science to be sustainable, win-win collaboration is the approach. All will win. For the question of finishing cancer to zero cancer, we arrive to zero cancer. No, it is just scientific, it is just TV talks. And but to be scientific, fortunately, cure, survival, quality of life, early diagnosis and detection prevention is much improved in the last years and will improve more. But talks about zero cancer and are still TV talks and slogan, but focused on scientific works, exploration, and win-win collaboration could lead to enormous innovation, progress of science, and unprecedented progress of cancer care and control in the world. This is the goal. Much progress and all will win. It's not romantic talk. No, because the winners will gain more and not less. We don't ask anyone to make sacrifice of the rich countries or the rich pharmaceutical company. No, we are seeking for that they will gain more. That's the present, but the present underserved will get the requirement with dignity in the real world, in the rich countries and in the poorer countries. But if we continue as we are, the crisis will increase for all. So isn't the time to be together? I leave the answer of this question to you. Is it the time to be together? Finally, the only hope to success of this scientific initiative is to be adopted, improved, implanted, and led by many of you. The notion of win-win is not competing or replacing or not invention, but it is a forum for all and belongs to all. Go on fruitful cooperation. Thank you all, and warmest regard and I hope you a very fruitful meeting and to learn from all of you. Thank you. Warmest regard, hand in hand. Thank you all.
Thank you so much, Professor Ahmed. I mean, nobody is more enthusiastic about global oncology. I've never seen anybody with that kind of energy like you. Thank you so much for that warm welcome. So we're going to move to the next part. We're going to invite our key speakers to present now. But the first one is one of my favorite global health colleague, Professor David Kerr, who really needs no introduction. I call him the doctor who wants to heal the wall of cancer. But let me say a few introductory comments about him. So Professor Kerr is actually recently, we were together as chairs of the Lancet Oncology Commission for Sub-Saharan Africa. He's a professor of cancer medicine at the University of Oxford in England. He's recognized internationally for his work in the research and treatment of colorectal cancer, and has published more than 400 papers. So besides being a great doctor, he's also a great science and research person. He has founded 3 Oxford University spin-off companies. In 2002, he was appointed the commander of the British Empire by Queen Elizabeth. And in 2010, he was elected the president of the European Society for Medical Oncology. He has led many clinical trials across the world, in India, in China, and now he's leading our Africa, Oxford, Harvard, Hopkins clinical trial network. He's really a visionary. One of the favorite things I remember about David was when we went to launch the Lancet Commission in Ghana, and he was the best dancer. We went to visit the cultural groups, and everybody just loved him. And I thought, what a wonderful way, to do global health diplomacy. I can go on, but I think for the interest of time, I would like to invite my friend David to go ahead and give his talk. David?
Thank you very much, Will. That was your Will is absolutely right. We invented a new science called dance diplomacy when we visited and worked together in Ghana. It was a wonderful visit, and we had a tremendous time together with the Lancet Commission. Wonderful to meet everybody, so that we're not meeting in person. But it allows me to talk a little about the work that we did with the Lancet Commission. It seems to me that at this particular time, today in the United Kingdom is a day of remembrance for us, for the glorious dead, those who fell during various world wars, we think, defending democracy and freedom at a time when there are many regions in the world in which there's conflict. It's important for us to remember that we've never been more connected. We've never been more connected as a global community, politically, physically, cyberspace, and through our understanding of genetics. Think about this. Each one of us in this call has at least 1 million relatives as close as a 10th cousin, and no one on earth, no single person, is further removed than your 50th cousin. So the more that we understand about the genesis of birth, about the bath of birth, the more interconnected that we are, the fewer the differences that we find between us. And these are the things that we must celebrate that pull us together as a community. Looking back across the centuries, there have been 3 global health revolutions. The first healthcare revolution we saw in the 19th century, which was all around public health, understanding the genesis of infectious disease, controlling it. The second healthcare revolution, which we as a group have lived through, was the application of knowledge, understanding the basis of genetics, of targeted therapy, of precision cancer medicine. But following on from what my great friend Ahmed said at the beginning, perhaps we're at the leadership in the vanguard of the third healthcare revolution, in which we should be driven by equity of implementation and putting knowledge into action. That may be what the driver that all of us are moving forward in this setting. Everyone gathered around this table understands the increasing burden of cancer, which will fall predominantly in low and middle income countries. But I think echoing what Ahmed said, what I hope the group gathered today would feel is that we meet with a degree of optimism with the steady progress that has been made, with understanding that with concerted early action, cancer is a disease that can be tackled at its root. And in collaboration with our colleagues in cardiology, diabetes, chronic respiratory disease, working together under the banner of non-communicable diseases. This is an awful picture, but this is a young woman that Will and I saw when we were in Ghana, 19 years old, and the problem of late presentation of disease. So my friend Twalib Ngomo and I were fellows in Glasgow almost 40 years ago. And then the patients presenting to him in Tanzania, 90% came with stage 4 disease. When I went to the Ocean Road cancer clinic some years ago, still the vast majority of patients were presenting with very advanced disease. Whether these patients were treated in Dar es Salaam or Oxford or Washington, the outcome would be virtually the same because of the massive burden of disease. So something we must pay attention to. Ahmed has implied this already. Our great friend Ala Alwan, whom is Deputy Director General of WHO, really put cancer on the WHO and UN map, told us that not only is it an enormous burden in health systems, but it's an enormous health economic burden. It undermines economic growth of nation states and acts as a chronic poverty trap for the poorest countries. And we can see here some calculations done by the UN, which we look at different countries, we look at GDP per capita and the economic loss due to cancer. So this, when we go to governments seeking collaboration to deal with cancer control, it's not just a problem of the health minister, but we need the finance minister, we need the economists involved, we need joined up government, not just the health department, when we're thinking about cancer control. So many of us gathered around the table today were involved and invited to take part in the Lancet Oncology Commission, looking at cancer control in sub-Saharan Africa. And again, let me pay great tribute to our friend David Collingridge, who's the managing editor of Lancet Oncology, and to Richard Horton, my friend who's the editor-in-chief of the parent Lancet Journal. Remember, the Lancet's celebrating its 200th anniversary, and the Lancet started as a newspaper, as an investigational newspaper, and taking that journalistic intent forward, they're very keen to bring together groups of experts, arranging a variety of different work streams. And from our work together over a period of a year, led by Will, by Beatrice, and some fantastic collaborators, we set out a list of 10 programs, which we think would make decisive steps towards reducing the burden of cancer in sub-Saharan Africa. I've listed these here. I don't think any of them will come as a surprise to you, but by bringing this group of highly influential clinicians and policymakers together, by providing the evidence base for each of these different programs, by understanding the power of each of them, we feel that that sense of convention, of coming together and sharing wisdom, allows us a platform to work with governments, to work with international funds, to work with individual clinicians, to work with patient groups, to see what we can do to drive this comprehensive but strongly evidence-based program forward. So do we need a global cancer fund? This is something I think we'll return to later this afternoon and in panel discussion. I would argue yes. I think there's much that we can learn from our colleagues in infectious disease. Remarkably, they've mobilized more than $30 billion over a decade from a variety of diverse sources, which they channeled and focused very capably to low and middle income countries to deal with AIDS, malaria, TB, and vaccine preventable diseases. This focus was driven by strong global leadership, civil society involvement, and activism by the affected communities, clear communication as to why there was an investment imperative. And that may be a voice that we need, that sense of activism by our affected communities. How many often do we see cancer patients or their relatives taking to the streets of major governing cities, asking for more resources, no, demanding it? Not often enough. But with resource mobilization, pooling of ideas, taking a collective approach, the infectious disease community has been remarkably effective, and one would hope that we could mirror that remarkable progress that they've made. It's impossible to be an academic from Oxford and not have some Latin quotations. So we'd always say, as Pliny the Elder said, Africa always teaches us something new, and it does. It's a partnership, as Amit has emphasized, that we learn from each other's. We learn from each other's in terms of our societal response to cancer. For me, who's interested in the genetics of colorectal cancer, can I explain why the incidence of colorectal cancer is increasing much more rapidly in the young, in African populations and Caucasians? Is there a mechanistic basis from it that allows me to explore it? And we would always say that knowledge is power. Namititsa scientias potestas est. But we would say knowledge is power only if it's shared. I think the key element of what we do. And these are the acknowledgements to the genuinely remarkable group of people that we brought together on the Lancet Commission. Thanks very much indeed for listening. Thank you.
Wow, thank you so much, David. Like you said, we are going to be able to come back, to further discussions with you during the panel discussion later on this afternoon. And so I'll request that everybody, whatever questions that you had for David, that you note those questions down, because we're going to have a chance for you to ask those questions and participate in that discussion. So we're going to go ahead and introduce just kind of a continuation of our key speakers for this morning. So the next key speaker that we're going to introduce for this morning is, Professor Hedy Ricak, who is the chair of the U.S. Cancer Monitor 2.0 Lancet Oncology Commission, and a professor in Memorial Sloan Kettering Cancer Center. Hedy is, become a really fun, is really a great leader who has really been focused on extending collaborations internationally. Her many international collaborative efforts have included leadership in the recent Lancet Oncology Commission on Medical Imaging and Nuclear Medicine. She is, of course, world-renowned for establishing the clinical value of MRI for prostate, kidney, and gynecological cancers. And she has really been at the forefront of creating collaborations with many organizations to demonstrate the survival and economic benefits to be gained from improving access to cancer imaging worldwide. And in recognition of her scientific accomplishments, she's won so many awards that I cannot even list, including 5 gold medals and 14 honorary fellowships or memberships from societies on 5 continents. That's just amazing. So I can go on, but I think I would like to give the chance to Hedy to be able to share about the Cancer Moonshot Commission. Hedy?
Thank you, Will. And it's really a pleasure to be here. As Will said, we have a new commission, and that's U.S. Cancer Moonshot 2.0, bi-directional collaboration to address oncology workforce challenges. And we were asked to focus on Africa and Latin America. Being from Memorial Sloan Kettering, we always have to show our disclosures, both as we serve on board of directors, as well as universities such as Johns Hopkins Advisory Board, and it's always international. So International Advisory Board of Vienna, as well I serve on both Scientific Committee, Board of Trustees for the German Cancer Center. So there is a growing concern about the healthcare workforce shortage. This is, I think, an excellent manuscript from British Medical Journal of Global Health, really pointing out of the tremendous shortage. They said 2030, which is just around the corner, of 18 million health workers. What is concerning is that that shortage will cluster in 47 countries that are on WHO support and safeguard. And in low middle income countries, they will bear 2/3 of shortage of physicians. And the global health workforce, I thought it was very well said, it's a further threat to equity and universal health coverage. For those that like pictures and colors, I think it's very easy to appreciate that now when they talk about healthcare workers, this is general, this is not just cancer, but I'm sure when our commission is done, it will be very similar for cancer as well. That there is the colors, the world is just too colorful. And while Canada, United States, Australia, and parts of Europe are dark blue, there is a tremendous shortage of the workforce, healthcare workforce, especially in sub-Saharan Africa, as well in Latin America. And I think this is why David Colgridge insisted that we include Latin America as well. So our commission will focus on Africa and Latin America, and the purpose of our commission is to define the scale of cancer care workforce deficit, but at the same time to provide solutions. And we all aim the same, deliver safe, effective, and efficient healthcare. Furthermore, we were really asked not only to provide the data and complain or write another paper, but propose a visionary and innovative short and long-term deliverables that would build an effective workforce. And with this in mind, we really put together, I think, a wonderful group of pillar leaders, are those that are going to be in charge of different sections, and really in commissioners that Beatrice is obviously on commissioners leading, that presents both Africa, both East and West Africa, as well as a good presentation from Latin America. So what are the pillars or sections that we need to address? First of all, we need to really examine current and projected landscape. Then we need to look at the obstacles and opportunities in healthcare delivery, and very happy to say that one of the people that you all probably know very well, and that's Richard Sullivan, is going to lead that part. Education, clinical and scientific training and leadership, and we're going to also address the brain drain from both Africa and Latin America. Research today is our healthcare, our work tomorrow, and we're going to address research workforce infrastructure because there's so much that we can, that we can learn. And we really think when we look at technology, especially AI and digital health, collaborative partnership, that's going to be that innovation that will come from our commission. And then economic investment and return on the investment. So we divided it in 3 parts, and during discussion, more than welcome on any comments. And that is foundational, interventional, what to do where there's education, research, and technology and AI, because we simply cannot continue to practice medicine the way we do today, either in the United States, UK, or Africa or Latin America. And then implementation with collaborative partnership and economic investment and return on investment being extremely important. Being physicians, we all care how to scale up our care and really look at, is there any way that we can avert cancer death? So if for 11 most common cancers, and that's from our previous commission, if we don't do anything, there will be 76 million deaths. If we scale up treatment and quality of care, we're going to prevent 5.5 million. But cancer care is a continuum, and we need not only surgery, but we need the infrastructure of diagnostics. And if we include diagnostics, then we're going to avert 9.5 million cancer deaths. So as physicians, we do want to invest in this project to really make cancer not go away or go by 50, but just improve cancer care. And then, as Professor Ahmed said, where is the money? What's the return on the investment? Well, healthcare, there's always return on investment. And in our study, we showed for every dollar invested, if you scale up treatment and quality of care, the return is 6.15. But if you put everything, which includes diagnostics, then the return on investment is double. I really very much like Professor Ahmed's comments on the financial burden on patients. We often talk about that as financial toxicity of cancer care. And this is why it isn't enough to show the data and to publish, but to make one step further. And I am really very proud to say that that one step further is making sure that patients can afford those diagnostics that are so essential. And because of the Lancet Commission on Diagnostics, I have to say Dr. Susan Horton and Ken Fleming were absolutely fantastic in carrying that next step and including data from imaging and nuclear medicine. They were actually that we passed the resolution on strengthening diagnostic capacity, and that was last May during the 76th World Health Assembly. Once that resolution is passed, then all the countries that are part of WHO, with further, of course, advocacy, should pay and that have national cancer healthcare plans, national healthcare plans should pay for diagnostics. So this will remove some of the financial toxicity on the patients. We can have all the CTs, all the genetic testings, all the labs you want to have. But if patient cannot afford, there is really no progress. And with this in mind, we have now embarked for another resolution, and that is WHA resolution on strengthening imaging capacity. We are using the data from Imaging and Nuclear Medicine Commission from 21, as well as very compelling data from Cancer in Sub-Saharan Africa that Will was leading, published in 22. We are planning to go forward with this resolution in 2025 because it takes a long time to put all the support together. And we really hope that this group we can count on and will support us as well. This is extremely important. Our resolution is requesting for our national health plan to pay for advanced imaging such as CT. Without CT, there is no radiation planning. Without good CT and staging, surgery is really in the old ages, as well as PET, and we're going to include theranostics as well. We think while it is advanced, radiotheranostics will be really the big next targeted therapy that we're going to put forward, and it needs to be included right now so the patient with metastatic prostate cancer will be able to have the PSMA treatment and not pay from the pocket. So with this in mind, I really like this Ubuntu, I am what I am, because who we all are, and collaboration together, I think, is absolutely essential. And with this in mind, thank you very much for your attention. Thank you.
Wow, thank you so much, Heidi. Really admirable of these efforts to on the World Health Resolution that you're really championing. And I like the quote at the end from Mandela and Desmond Tutu, really emphasizing the need for collaborations, that we are all together in this. That's really, really important. I would mention that one of the things from your presentation on the Lancet Commission also points to the bidirectional learning component, or bidirectional collaborations or benefits that are going to result from the Cancer Moonshot Commission. It's really important because I think, it's really the win-win that Professor Ahmed mentioned. So, when you invest into this, not only low and mid-income countries win, but the United States also wins. And I think same thing for UK or other high-income countries, looking at global health from the lens that there's also a benefit for high-income countries. So we're going to have a chance. Please keep your questions for Heidi at the end during the panel as well. And so we are going to move forward now to really look a little bit. I know Professor David did show the picture of the woman with the breast cancer. And I think it's really important because sometimes we do all this work and we wonder, it's really nice to be able to see the face of the people, the impact that we are having, where the needs really are. And I think that, so now we are going to transition to kind of have a couple of presentations, just short 5 minutes on the 5 to 10 minutes, I hope 5 minutes, but from advocates who are basically telling us why we should extend the Cancer Moonshot globally and why global collaborations are really, really, really important. And the first person who is going to talk about this is the person we call Warrior Mama. So that's Julie Chessel. She's an award-winning author and big cancer advocate. So we are going to welcome Julie to give her presentation now. Julie?
Good morning. Good morning from Canada. Such a nice morning to see some familiar faces from the past. And I'm so grateful to be here. So thank you very much. So I am Julie. I am sitting here in my office in Canada, and I am the mom of three amazing boys, 19, 17, and 15. And I've been a practicing registered nurse for almost 24 years. So my story starts about 5 years ago. I was just, working along. I'm a team lead in a very busy labor and delivery NICU pediatric area. And as nurses, we help people. We're in healthcare. Our mission is to see the problems and try and fix it. Well, I didn't see the problem that was right in front of me. And that was at the time my 12-year-old son. I looked at him one day getting into the shower and thought, wow, you're skinny. And our journey started there. He was diagnosed with stage 4 hepatoblastoma, and his tumor had some HCC properties in it. And that catapulted us into a life of the unknown. How do we access the best healthcare possible? So if you could all close your eyes just for a second, if you can, the ones that are on screen, the ones that aren't, I want to take you through a little journey. I want to take you through a journey of what it's like to be a caregiver, a patient with cancer, or a loved one. So holding that image of a long stairwell, if you can, just for a second. It's hard to put all those feelings and life-changing that the word cancer brings into context. So a vivid metaphor for that is this endless staircase of a poignant and emotional portrayal of an experience of having a loved one with cancer is like. That initial shock and disbelief, represented by the echo of the devastating words, give way to the relentless and exhausting climb. So remember that staircase, it just goes on and on and on, symbolizing the journey through the challenges of cancer treatment. The description of climbing together, hand in hand, captures the unity and strength of caregivers and loved ones facing that uphill battle. The surge of adrenaline reflects the immediate response to confront the beast. So I like to call it the beast of cancer head on. The absence of time or rest emphasizes the demanding continuous nature of that struggle. So as that climb progresses, the realization sets in that this journey is shared by many others. Each of them have their unique own stories and stages in that process. That metaphor of climbing higher in the stairwell highlights the increasing difficulty of weariness on that journey. The shared experience with others on similar paths fosters a sense of community and understanding. The hope to get to the top symbolizes the aspiration for a positive outcome, but the acknowledgement that there's no guarantee of a definitive end adds a layer of uncertainty and anxiety. The observation of people walking down alone with empty arms serves as a stark reminder of the potential loss and tragedy that can accompany this journey. That congested stairwell, filled with both pain and joy, becomes a powerful metaphor for the crowded and often overwhelming environment of dealing with cancer within the healthcare system. The lack of visibility from the outside world accentuates the isolating nature of the experience of those outside that metaphor building, and that they may not comprehend the struggles within. So ultimately, the narrative, so this narrative that I just said, conveys the complex emotions, challenges, uncertainties that accompany the journey of having a loved one with cancer, offering a poignant reflection on the shared experience of those navigating this difficult path. Whether I'm in Canada, whether it's the US, or whether it's Africa, we're all joined together with that journey. Even though our journeys may look different, it is the access that we're going for. It is the research and the collaboration that we're going for. So when Brock was diagnosed, we found out that it was stage 4, that it was 16 rounds of failed chemotherapy, that he was palliative, and the only way that he could survive was a liver transplant. So thankfully, he is 17 years old today, a mouthy teenager, a boy mouthy teenager who just bought his first car and who is going to apply for university. But not everybody gets that chance. And that is why we're all here today. How do we access this universal health care? A new generation of philanthropists, academia, scientists, researchers, we're all coming together now. We're trying not to be in that silo mold, right? That silo of everybody's working for themselves. We need to all come together universally, globally, so we can cancel what I call the beast that cancer is. We need research to further. We need precision medicine and immunotherapy, but access is that big question. Brilliant science is here. Brilliant investment is here. And we need brilliant scientists to continue their work. When President Joe Biden and Dr. Joe Biden ignited this moonshot in February, they set ambitious goals. And as Will said, 50,000 over the next 25 years. The death rate to drop. We need this to happen. This is an achievable goal if we work together, if we're not in that silo model. We need to improve the experience of people and families living with cancer, surviving cancer. That's what it's about. Even if we survive and thrive together, ultimately ending cancer as we know it today. They, Dr. Biden and President Biden and Dr. Biden have called for everyone to do their part. So here we are today. How amazing is this? Saturday morning, whether it's afternoon or morning, we're all doing our part, whether it's federal agencies, departments of private companies, healthcare providers, that includes me as a nurse, patient groups, there I am again, philanthropy and more. While the immediate goals are domestic, the ambitions of the moonshot extend far beyond, and this is why we're here again today, far beyond the borders of North America, especially as the burden of cancer falls heavily in the low to middle income countries, where 80% of global cancer deaths occur. So international work as part of the moonshot is focused on equity, collaborations. That's what we're doing here today, collaborating and having care for everyone facing cancer, the diagnosis, their families, as we just heard, the families, the financial toxicity. And the financial toxicity doesn't start necessarily right when your diagnosis is. That financial toxicity can carry for years to come. So, my friends, as we know, cancer is universal. We have all experienced it in some way, shape, or form. It does not discriminate. It doesn't matter how old you are, what form it is, what ethnicity you are, and from what economic background. So as we work together for a common goal, you and I, we're all here, we become unified. We must come together collectively to raise our level of conscious awareness, to achieve partnerships for health. We are called to come together to pull our knowledge, our resources, our contacts, and most importantly, all of our hearts. That should be the star that we're shooting for, to become more effective as a collaborative mind, to become more mindful of how we can achieve this. So the question I pose to you is, how can we brainstorm? Let's get started today. Thank you.
Thank you so much, Julie. You speak with so much passion and conviction that, we really, I can emphasize how important it is to have patient advocates like you. And obviously the story of you or your son, of your child, really provides inspiration for us on what, is possible. And even as we talk about the Global Fund or collaborating to fight cancer, we're going to need all the patient advocates. We're going to need the advocates like you, or even for the World Health Resolution that Heidi talked about. So we look forward to working with you going forward to be able to achieve these goals and have a bigger impact. So next we will talk about, we'll welcome some other award-winning, this time young people, because most of this work we are doing is really important for the future. So we want to make sure that we engage the young people, the next generation, in these efforts to address cancer. And so today I'm going to welcome the Kids Fighting Cancer to give the short presentation.
Hello, my name is Ari.
My name is Gabby.
My name is Gavin.
And I'm Logan, and we are Kids Fighting Cancer. Our goal is to help educate kids
around the world about cancer and to give resources to kids who have cancer. My aunt is battling a type of cancer called multiple myeloma, and this causes her to take chemo about 3 times a week. This causes for me to miss out on time with her that I would do anything to have. This is one way that cancer has touched my life and the life of my family, as it has with so many other children around the world. That is why when I heard Dr. Young at the 2023 Global Health Catalyst Summit from the Biden administration talk about Cancer Moonshot, we all together were ecstatic about this. She said that the Moonshot wanted to work towards decreasing cancer deaths by 50% in the next 25 years and improving the lives and conditions of people with cancer in the United States. Now, Global Health Catalyst is advocating for Cancer Moonshot 2.0 so that these efforts can be extended to around the globe, to everyone.
With the Cancer Moonshot 2.0 initiative, the potential for outreach is even greater. And today, we would like to bring to attention not only consideration for adults with cancer, but also specific considerations for the kids who have loved ones with this disease. The Cancer Moonshot goals include not only helping people with cancer, but also their families. By supporting affected children, we are able to live up to this promise. Having cancer can be scary, not only for the patients, but also for their loved ones. And this includes the kids and the other people. Around 400,000 kids have cancer in the world. But what is often left out is the fact that many kids are still indirectly affected by cancer, whether through having a parent, guardian, grandparent, or even a sibling who's fighting cancer. They are still involved in this fight.
People are people are negatively impacted by cancer, and these people include kids who should not be overlooked. Kids suffering from cancer or dealing with a loved one who has cancer need love and support to help guide them through a time of uncertainty. We have recommendations that can help specifically kids affected by cancer. The first being to educate specifically kids about cancer and cancer treatments, because knowledge is power, and with it comes understanding that blocks out fear. We created a Lego stop motion called Kids Fighting Cancer, called Avengers versus Cancer. That is an example of this, using creativity to help educate kids about cancer. Another suggestion is that parents or caretakers receive time off from work while still being provided with a stable salary. This ensures that parental guardians can spend more time with the child affected by cancer without worrying about their next meal. Another recommendation is providing free tutoring for children affected by cancer who are able to continue schooling. This is because education is important, and kids shouldn't have to worry about grades while dealing with cancer. Speaking from experience, trying to catch up with school after even a week of sickness is a struggle. So I can't even imagine months or years spent not being able to give full attention to schoolwork. Additionally, pets providing emotional support could also have a positive influence on these kids. Access to friendly pets could be a welcome distraction from time to time. Finally, expression through the arts is another simple way that kids affected by cancer can freely express their many thoughts and emotions and receive therapeutic assistance. By providing free art kits, music classes, or theater tickets and other opportunities to express themselves, kids can stay positive. All of these ideas could significantly support kids fighting cancer or even kids who are coping with a loved one going through cancer. And these ideas can be achieved through collaborations.
I'd like to share with you all what our mission is. We want to spread cancer awareness for kids all around the world. We also think it's very important to create a network so that we can match children with cancer to those people and organizations that can truly make a difference in their lives. We already have lots of ideas on how to accomplish this and tools that are under construction, such as a website that will reach millions of children around the world. On this website, we will have such things as inspirational stories of kids who beat cancer, age-appropriate resources with easy-to-understand words for kids of all ages, fun games and animations that teach about cancer and different types of treatments. We want to play a role in spreading the goal of reducing cancer death rates, but not just here in the US, all around the world, because every child deserves that kind of hope, that kind of promise. So please, help us advocate for those who can't. We support that the Moonshot Initiative should be extended internationally, so every child has a chance to reach for the stars, or in this case, the moon. Thank you.
Thank you.
Thank you so much.
Thank you.
Yeah, this is so powerful coming from kids. It's really powerful. And following Julie's presentation and sharing the story about a kid, for these kids to come on and really inspire us all, I think, that leaves us all our work cut out for us. All of us need to work together to secure a future for our kids. So now we are going to transition to being able to learn. Since we actually launched the Cancer Moonshot last year, I would want to share what happened when we launched the Lancet Oncology Commission. And then last year, December, we had President Biden host African leaders in Washington. And following that, there was a commitment by the White House to extend, about $350 million in terms of funding initiatives to Africa to fight cancer. And so today there's been, a lot of progress has been made since we launched the Lancet Oncology Commission for Sub-Saharan Africa. And that's just one example. But I would like to call now on three distinguished panelists who are going to talk to us about what are some of the progress or initiatives that are going on in other parts of the world. And the first person that we're going to invite to speak is Professor Stephen Avery and Dr. Beatrice Adai, who I understand is traveling, so may not be able to participate. But I think Stephen, who is just coming from Ghana, will be able to share with us about the opportunities of collaborations to extend the Cancer Moonshot to Ghana. My friend Stephen, are you there?
Yeah, I'm here.
Good.
Thank you, Will. And yeah, thank you for this opportunity to really share some of the progress that we've been making since the meeting that we've had. This all started, like you said, in May of 2022 in Ghana when we launched the Lancet Commission. And from there, we had a list of calls of action, and we were very motivated to carry out this ambitious project that we've had. Since then, like Will had mentioned, we had the meeting in DC. And after that, we had a Global Health Catalyst meeting at the University of Pennsylvania, where our young catalysts just mentioned, some of their experience. And we talked about developing a center of excellence in Ghana. That was one of the really main themes that we had coming together. And with that idea, when we left Ghana, we were talking about developing education programs where we would really increase the workforce that's needed, especially with medical physics. Along those same lines, we also talked about developing a center of excellence for AI, because as we understand, this is going to change the whole paradigm of how we deliver healthcare. And so we think an AI center in West Africa is ideal. We also talked with university leaders from the University of Ghana, the Kwame Nkrumah University of Science and Technology. We talked with some leaders from South Africa. And so one of the things that came out of that was that we wanted to have a symposium or a meeting really focused on bringing together this consortium with a focus of being the leaders of AI in Africa. Since AI is something that is being developed, one question that has been answered is, how does AI affect the continent? Because the patient population is very different. So the tools that may work in one area of the world do not necessarily work on the continent. So we really need to explore and look at this question. In addition to that, we also want to look at bringing together students from around the world and from lower and middle income countries together. Like, again, these young catalysts are so inspiring to me. Whenever I hear them, it just makes me say, I just want to work harder. But I think to bring these students together so we all kind of understand what are some of the disparities that we face and how do we work together, to answer these questions. One really, really good outcome that came from this meeting in Ghana is that Beatrice, who is an amazing person in herself, we were able to have an appointment with the Asante King, who has pledged to help us raise $100 million in order to develop this Center of Excellence, which I think is something is an amazing feat, I think, for us to accomplish. So the plan is to have a groundbreaking in April of next year, which is the 25th anniversary of the King, to celebrate that. We actually would like to name the center after the King in collaboration with our Global Health Catalyst. So although I think about it, it started in May of 2022, and this is, we're going into only 2 years of what we've done so far. And just to think about it is like, we've accomplished so much. And I think we, are going in a direction that is, 5 years from now, we're looking to just, I just wonder what's going to be developed, once we have really, began some of these collaborations. We're only at the beginning. We have a lot to do. And so I know I only have 5 minutes, but I want to, just let everyone know that that we're only starting. And this commission, I think in a couple of years, we're going to look back and we're going to say that we've done some really good work here and we've helped a lot of people. And I think this is going to be a great accomplishment. I'll stop there in order to save time.
Thank you so much, Stephen. That's amazing. I saw your picture with the king in Ashanti King in Africa, and I was like, wow, you are becoming royalty. So hopefully some of us are going to rub off on that. And I mean, this is really in the spirit of London Cancer Week. I mean, these collaborations, the idea of having a whole week where we dedicate to looking at cancer and collaborations in other parts of the world. So, being able to hear that, Ghana is looking to set up this $100 million, this initiative to set up a center of excellence, just amazing. So, that really calls us all, inspires us all, to look at ways that we can continue to collaborate and also support this initiative. So next, I should mention that Stephen is one of the directors of the Global Health Catalyst, and has really, like you mentioned, had a really successful event at UPenn earlier this year that has really catalyzed a lot of these collaborations. So I'm going to invite another of the leaders as well, Professor Saiful Haq, who has really been leading some of the initiatives, extending some of this to Southeast Asia, to be able to share what some of the outcomes and efforts are currently in Southeast Asia. Saiful, are you there?
Yes, give me 1 second. I have a few slides that let me share. Okay. Do you see them?
Yes, sir. We see them loud and nicely. Yeah.
All right. Well, thank you. Thanks, Will, for that kind introduction. And good day, everyone. Let me get myself organized here. So I have only 5 minutes. You've heard from Professor David Kerr, Hedvig, and my good friend Will. They're speaking so eloquently about the importance of win-win global collaboration to accomplish the goals of Cancer Moonshot 2.0. And you also heard from Julie Chassel. She has so passionately articulated the reasons why we all are here. We are all part of a global community, and each of us are contributing in a very small way. So I'm going to talk about extending the Cancer Moonshot 2.0 initiatives to South Asian countries, known as the SAARC countries. These countries are Bangladesh, India, Pakistan, Nepal, Bhutan, Sri Lanka, Maldives, and Afghanistan. The total population of the SAARC countries is 1.92 billion, which is about a fourth of the world's total population. So you can see these countries have a significant potential to contribute to the success stories of Cancer Moonshot 2.0. So the Global Health Catalyst, in collaboration with Oncology Club from Bangladesh, held a day-long summit in Bangladesh this past September, where participants from all the SAARC countries participated. We undertook various initiatives to help accomplish the goals of Cancer Moonshot 2.0, and I'm going to mention just a few of them. So building on the success stories of the Lancet Commission report on Sub-Saharan Africa, and after discussion with Professor David Collinridge, we have taken an initiative to write a series of 5 papers in Lancet, which will focus on cancer care and outreach, education and training, and research. And 4 of these papers will essentially identify the gaps to bridge the Cancer Moonshot 2.0 goals in the SAARC countries. And the 5th paper will focus on cancer prevention, cancer care, and outreach among the Rohingya refugee population in Cox's Bazar in Bangladesh. Will and I met these young, kids, I would say, this from the Rohingya population. I mean, if you meet them, it just blows your mind as to what they're going to do to address some of the challenges that the Rohingya populations are facing currently in the world. And so we strongly believe the national response to call to action highlighted in these papers will have similar impact on the SAARC country populations as we have heard or seen in the African countries responding to the call to action that have been highlighted in the Lancet Commission report on the Sub-Saharan Africa. As we all know, cost and access to care are major problems for receiving high quality care in the low and middle income countries. And SAARC countries are no different. To cut the cost of healthcare expenses and improve access to care, one of the initiatives we have undertaken is to start a multi-country clinical trials among some of the SAARC country members using low-dose immunotherapy for advanced head and neck cancer, which is one of the major contributors to mortality and poor quality of life in these countries. We are also exploring to start a multi-country hypofractionated clinical trial for cervical cancer in these countries. As you know, about 600,000 new cases of both cervical cancer and head and neck squamous cell carcinoma, they were diagnosed in the low and middle income countries in 2020. And about 90% of the cervical cancer related deaths occurred in low and middle income countries. Our hope is that such initiatives will provide effective, safe, accessible, and affordable care for patients diagnosed with these 2 cancer types. Additional initiatives that we have undertaken involve working with the various NGOs in Bangladesh to help eliminate cervical cancer and on work on capacity building in the healthcare sector. We'll be using the Global Oncology University platform, one of the initiatives of Global Health Catalyst, to build capacity in the oncology workspace, particularly, educating the medical physicists, the therapists who are involved in the treatment of cancer patients in the radiation oncology space. You have heard Professor Kerr saying that Africa always teaches us something new. And there's a new proverb that I really like. It says that if you want to go fast, go alone. And if you want to go far, go together. This is one of the African proverbs. and collaboration is the key. You have heard it again and again in the presentations today. These are some of the collaborators, in the South countries who have we're really championing the initiatives that we have undertaken. Thank you very much.
Thank you so much, Saiful. I always say you always have one of the best slide deck. You take time to prepare this, and it's really wonderful. And we're really excited about what's happening in the SAARC countries and your leadership in being able to extend the Cancer Moonshot and the efforts that we're doing there. Fantastic. Like you said at the end, really we need collaboration if we want to go further with the African saying. So we're going to we'll soon transition into the panel discussion where we can have everybody participate in asking questions and to the speakers. But we have one last short presentation that's going to talk about, some of the efforts of extending the Cancer Moonshot as well in the Lancet Oncology Commission for Sub-Saharan Africa in Tanzania. I understand that our dear friend, Professor Twali Ngoma is on right now. Professor Twali. Okay, fantastic. Great, excellent. Yes. You have the floor. There you are.
Very much indeed. And good afternoon, everybody. Good afternoon, David K. and everybody. You see, when Will told me that there is this opportunity to present our experiences in Tanzania, I was very delighted. I'm happy now to share with you our experiences in Tanzania. The Lancet Commission on Cancer Control in Sub-Saharan Africa came with some recommendations, and I happened to be one of the commissioners. My section was on workforce. Workforce in cancer control is like everything, because without workforce, nothing gets done. Even in a recent meeting, outing meeting, when some of the commissioners who attended the meeting were asked a question about what do they think was the most important thing they would do if money was not a problem, they all unanimously said they would invest in workforce. However, today, because I'm talking about the experience in Tanzania, and I'm going to focus on one of the recommendations, which was to establish of excellence, which would be the hub for the services in the region. Through the efforts of the Global Health Catalyst and our US Embassy in Washington, establishing Oncology Center of Excellence. It's an ambitious project that we are confident that it's going to be successful. There is already buy-in and commitment by the government of Tanzania. A committee to work on this has already been formed, and it has been working on this for the last 8 months. Where we're going to have a memorandum of understanding signed around January next year. At the same time, we are working Investors Forum, which will be held in Tanzania in January next year. We think that looking at the Lancet Commission recommendations, if we set up a center which would act like a hub for the East Africa region, one, the other efforts of cancer control would be working well if there is treatment already available in the region. What happens now is for the state-of-art treatment for few patients who present to hospital with early disease, they have to be sent outside the region. And most of them are referred to India. In a situation like this, very few are lucky to get that service. So having the service here in the region means that there will be more access to state-of-art cancer services in the region. There will be a component of training, which means that will address the workforce. There will be a component of education, research, and all these are things that are very important in cancer control. So in this London week of cancer, I thought I should tell you what is happening in Tanzania and just focus on the Lancet Commission recommendations. Thank you very much. This is all what I wanted to share with you.
Thank you so much, Dr. Twalib. Yeah, we're very, very excited about what's going to happen, in Tanzania, where the government is really taking leadership on this already and really committing to setting up a regional center of excellence that can serve not only the region, but actually Africa as a whole. And even the idea of having a medical tourism hub in Africa where even people from the United States can then go there and have access to care, it's really captivating. So really look forward to seeing how this initiative continues to progress. Now we will move to our panel. And I just want to go back to what David said at the beginning, which was really the idea that we are exploring this concept of a global fund for cancer and being able to advocate for that so that high-income country governments in collaboration with stakeholders also in low and middle-income countries can really invest into this kind of initiative that can help us end cancer as we know it. And so, if you had questions during the presentations until now, we'll have an opportunity now for this panel to address that. But before that, we actually would like to have introduce one of the panelists to share. The question is really going to be, if money was not an issue, let's say we had this global fund for cancer, what would be your priority? And I think the first panelist that we would like to welcome to speak is Dr. Moni Kuriagos, who is going to talk about digital health, and it kind of aligns with what Stephen said earlier on with AI and technology. And I think that's one of the areas where I think investment can really, change or transform cancer care. So, Dr. Moni, are you there? Great. Please go ahead.
Thank you, Will. I represent an organization called Karkinos Healthcare. We heard during this morning's presentation various challenges we are facing in low and middle-income countries. So I'm going to submit to you that these challenges can be transformed into opportunities provided we adopt technology. Now, as a practicing clinician, I see the statement we made earlier, the widening gap of access and affordability. And if you look at that, the widening gap, the root cause of them, it's because the complexity involved in cancer care, And then because of that, the lack of adherence to or compliance to treatment, although we have various guidelines available, but when it comes to practice, it cannot be implemented. And there is the healthcare itself is rather fragmented. Patient need to move from one place to another to provide care. And the last but not least is that although patient move from one place to another location, the data or the information doesn't move. Now, how can we address that? This is our basic hypothesis of premise. If you look at the healthcare, cancer care, it's in a pyramidal fashion. Bottom of the pyramid, we heard about the late diagnosis that's supposed to be given by the primary healthcare. Then various levels of cancer care, right from daycare to the most complicated cancer care, which we heard earlier, Center for Excellence. And all this is actually, if you look at it, rather fragmented. Imagine, no, this is in the terrain of imagination, is that right? Imagine there is a knowledge base available, and that knowledge base varies from various levels of care. And there is a technology to infuse the care where it's appropriate. I believe that that is feasible. I'm going to show you some data about that, what we are doing here in India. What we have done is that we have developed a tech platform which address every touch point of the patient, right from early detection, diagnosis, we heard about diagnostic issue, and then that fragmented healthcare, and use this information for newer insights or discovery part of it. What we have done is that rather than focusing on physical infrastructure, think about developing a technology infrastructure for early assessment. In a country like India and most of low and middle income country, we cannot screen every patient, but evaluate the high risk population, do the risk screening, and do the appropriate diagnosis, and then develop a virtual platform to make the decision making and take the patient from end to end to improve the cancer care experience. So this is a front facing of that, the applications. We have various applications for risk evaluation, for empowering the health workers, the clinicians for diagnosis, various virtual tumor board, and the care coordinations, and so on. All this information is passed into what we call Care Cloud. And just to give the front end of this platform, we have the risk evaluation. So you and I can evaluate whether we have elevated risk or not. And then we have something called the central command center. Command center is both physical as well as digital. Three main job of this command center is patient navigation within the stakeholders, within an organization, or between organization from diagnostic center to other facilities, so that there will be a seamless care coordination happens during the entire journey of the patient. Second aspect is decision making. This call is taken by multiple people sitting in various parts of the country or globe. And now there is no reason why the expertise cannot be brought into the people at the edge where the decision can be made. Once the decision is made, implementation is fairly straightforward. So a virtual tumor board, I will demonstrate some case of that. And then we heard about the issues with the manpower. We work with Guy's and St. Thomas Academy, Cancer Academy, to develop a learning platform to upskill the knowledge. Now, if we have this tech platform, we can transform any existing health system or health clinic to what we call a community cancer clinic. Various elements I've listed here. I will not go into details of that. So they can play a role in the cancer care rather than a site. Now, just to give you some data from our last 2 years of clinical operations, we have risk evaluate 1.4 million population, and out of that, 12% had elevated risk for 5 common cancers we see in the country. Previous speaker mentioned about cervix and head and neck cancer. Out of that, 3% had either pre-cancer or cancer. Not only we diagnosed cancer, almost over 40,000 cancer patients or those who are suspected, the care we navigated using the platform. Now, I'll give you some case case studies. This is a village in the southern part of India, population 10,000. Eligible population for screening is about 7,500. What technology did was using the existing manpower, using the technology, we risk evaluated within about 6 weeks of activity, about 60% of the population. What is important is a table on the right side. During that 6 weeks time, we could impact the life of about 200 people, either early detection or early intervention. Now, give you some stories about some of these patients. This is a well person in that village. HPV was positive, and then patient went to a local community, what we call community cancer clinic. A corpuscopy and biopsy was done. Biopsy was moved to a central lab for a biopsy interpretation, and for surgery went to a nearby hospital for a simple hysterectomy, and then the care was coordinated by the community cancer clinic. Imagine the technology behind that, multiple care players. So we converted the entire community as a cancer care. We took the cancer care from the walls of the 4 walls of the cancer building to the community. Not only simple case like that. This is a patient evaluated with a neck lump. Diagnosis of papillary thyroid cancer, straightforward case. But within about 3 months, patient recurred. And then the patient is a difficult problem. Rather than then the patient underwent a PET scan, and then we did a genomic testing, very affordable genomic panel we developed that identified 2 mutations. Then the patient was recommended therapy, again sitting at home. So what happened was the care was coordinated, got the best care someone can get in Oxford or wherever for this person sitting in a village in India. This is feasible because of technology. Now, the back end of the technology, I will not bore you with the details of that. The front part I mentioned to you about various applications. That application is pulled into various services, EventBus, which I mentioned earlier. And all this data is pulled into what I mentioned earlier, K-Cloud. This unstructured, this data is captured in a various sources like MCODE and HL7 and everything. This unstructured data is converted into structured data. We heard about the AI ML. This is feasible only if the data is structured. So then now, thanks to the Government of India's digital mission, we have rules for data sharing. And this platform allows to engage with multiple players. Now, the power I mentioned to you earlier about this, how to convert this challenge into an opportunity. Imagine this data is captured at various longitudinal clinical information, imaging information, pathology. We heard about the uniqueness of each population. If you have a database of Africa with its longitudinally carried, the power is and we can change cancer, and we can change the cancer the way we see it. And just to summarize, so this is the activity. I will not go into details of it. So this is a future, ladies and gentlemen. We can incorporate technology into physical infrastructure to change the cancer as we see it. Thank you very much.
This is wonderful. Thank you, Dr. Moni. I mean, I think I actually am a fan of this, investing in technology. It can really transform care and access, and one of the things that we've actually been talking about also in Africa is thinking about, creating a cancer center in the cloud. And you just showed that case, very convincing, that you can do that in India. So, I mean, this is fantastic. I think that already answers one of the questions we're going to have on this panel, where should you put the money? And I'll just mention one more thing there before I, let the other people contribute. So it's really the fact that it's actually one of the areas where the Cancer Monitor has identified, in investing is in technology like this, AI and data sharing, which can really be win-win, because some of these things that you learned there can also benefit high-income countries, these models. So thank you so much for that presentation. I'm now going to welcome Dr. Or one of the luminaries in global oncology, who is going to share his own thoughts on this. If money was not an issue and you wanted to, prioritize, if you had this global fund for cancer, make a case for that. Where should the focus be? And that would be no other person than Professor Eduardo Casap, who has so many titles that I'll just let him. He's the founder and first president of Latin America and the Caribbean Society of Medical Oncologists, LACOM. He's been the president of UICC. He is the editor of eCancer. He's done so many different things. And we are so honored that you can join us today. He's actually on the board of London Global Cancer Week as well. So welcome, my friend, Dr. Kazab, if you're there.
Yes.
Okay, fantastic.
Yes, Will, thank you very much for this kind invitation with so many luminaries of the global effort. I would like to share with our colleagues 2 or 3 points that I think are necessary in order to truly understand what is global. Because global is true for communication, it's true for many things. It is not really completely true for health. Because healthcare systems, funding is independent, it's based in each country. So global efforts should be very cautious, defining strategies on how the money that can be allocated will be used. And a quick example, the ODAs, are the official development assistance. It's the money that all governments of the world contribute for many actions, water, pollution, health. During many years, the number one disease that received money was AIDS. I don't have updated numbers, and some years ago it was $7 billion. Do you know the ODA's contribution to all NCDs? All NCDs, cardiovascular, lung, diabetes, and cancer, $300 million, a very small percentage. So I am completely in agreement to develop a global cancer fund. With any doubt, it is a world urgent need, with a question: how that money will be allocated? In my view, governments are not the best stakeholders to be part of this equation. But that is a question to be solved after many intelligent cancer people in the world many years ago, of course, David, but also Franco Cavalli many years ago at the Swiss Senate, and other people are promoting the idea of a global cancer fund. The second point that I would like to share with you is the issue of global and local. We think that the top-down or bottom-up strategy is fundamental for global actions. If not, it is very difficult to implement things with the local people is not aware or is not ready or has not the necessary basic elements. You know that in the African situation. Latin America is different. Latin America has many resources, has money, not much, but in Argentina has 10% of the GDP applied to health, but the results are poor. And that is the situation of most of the Latin American countries. In order not to be taking too much of your time, I would like to resume the issue of global and local with an example. Several years ago, at the time that I was president of the UICC, we started the City Cancer Challenge. The City Cancer Challenge was an experiment with global support, but acting at the local level with the local people that are using their own knowledge, technology, resources, contact, partnership, collaboration. One of the first countries was Paraguay. Since then, a few years, Paraguay, one of the less developed cancer control countries in our region, has a national cancer law. 2, a fantastic coalition of all cancer control players in Paraguay that was really obtained through the global collaboration. Why? Because during decades, the Paraguayan doctors were not working together. But the call of the UICC was necessary to gather the people from a global convener. So I would like to summarize my 2 points that are, I think, vital in the global discussion. Yes, global, but global with local. Otherwise, the efforts are really much more complex and also costly. Second, the governments must take this responsibility. The governments are not supporting cancer care globally. Governments are looking to another place. Governments are not interested because cancer has not political benefits. So a call to the governments to collaborate. Second, a call for a global, local, real partnership in the implementation of actions. And that is the true value of Cancer Moonshot 2.0, because the first attempt from President Nixon in 1971, the War of Cancer, to end cancer for the 2000 was, in my concept, not well designed, because it was centered only in research. Now, the new initiative for President Biden has a very important point, perhaps the only important point that was mentioned by our dear David: implementation. We need no more documents, guidelines, planned. No, we need implementations and real actions at the local context with the necessary resources and at the level that healthcare systems and population needs. Thank you very much for your attention.
Oh, thank you so much, Eduardo. I mean, I think that's fantastic. I mean, with your experience, I think that's really true. Being able to have that local buy-in as well, making sure, like Stephen highlighted earlier on with the Ghana, looking now to even be the leader in this, we want to look at the global, but also local focus, making sure that, it's really relevant and there's buy-in from the locals. That's a really, really important point. And I know that the London Global Cancer Week is really helping to mobilize action from governments to really address this global pandemic, to your second point. So I think that that's really important. It's time for action for us to collaborate, including the governments. I'm going to now welcome for the same question, about the Global Fund and the priority, Jennifer Dent, who is the president of BioVentures for Global Health, to give some comments on that. Let's, because of time, probably 2-3 minutes.
Thanks very much, Will, and it's a pleasure to be here. You always bring together such a fantastic group of experts, and also really a diverse group that represent all of the key voices that are so important in the global cancer care space. So briefly, the organization that I represent, BioVentures for Global Health, launched the African Access Initiative in 2017 with 5 core objectives, ultimately to improve cancer patient outcomes in Africa through a holistic and kind of across the cancer patient management pathway. So from actually expanding access to medicines, training oncology healthcare professionals, strengthening diagnosis and key infrastructure areas, enabling cancer research that's determined and led by African oncology healthcare professionals, and also supporting advocacy. And like everyone that's here with us today, we were really inspired when President Obama launched the Cancer Moonshot and had at the time Vice President Biden kind of lead that effort. And when President Biden became the president and launched the Cancer Moonshot, and then in December of last year extended the Cancer Moonshot to Africa, we saw that as just a huge opportunity to drive collaboration internationally to improve some of the activities and extend some of the activities globally across the key areas of objectives of the Cancer Moonshot. And our organization made commitments in alignment with the work that we were doing to expand access, to also extend cancer research programs. And here on this call today, we have many of our partners represented. We also have been focusing our efforts on training oncology healthcare professionals. And I think Hedy covered so many of the important kind of critical topics on training healthcare professionals, and that there is a tremendous shortage in Africa of trained healthcare professionals. So we see that as really a critical component of improving cancer patient outcomes on the continent. And that's an area where we've been working with international partners to conduct digital training programs, also in-person workshops, fellowships, knowledge sharing, tumor board sessions, through a number of mechanisms to work with partners in Africa to strengthen and expand their capabilities and knowledge. One aspect that I think is absolutely critical is just the concept of sustainability of initiatives. And for sustainability, they have to be really led and championed by local partners. So at BVGH, we apply a holistic approach to understanding what our partners on the African continent want to achieve, and then working with them to design and map out and develop and implement those programs, whether it's access, training, or research. And so just wanted to highlight, I think that the training is absolutely critical, and also to highlight that this is actually good for the United States. And I want to include, Julie, I loved your, I think your messages were so critically important. But I think including Canada is important too. I mean, Canada, the United States, Europe are leaders in innovation. And it's absolutely critical and good for the US to take its innovation, especially in areas like cancer control and cancer patient management, where I think the US is the leader in advancing healthcare in these areas. So actually taking those innovations in partnership to Africa is good for the United States from a political, from a security, from an economic standpoint. And so I think we have to change the way we think about kind of delivering support to African countries. These are true partnerships. Everyone benefits. And by expanding access to care, by extending our research programs like the Hypo Africa program that we're very excited to be collaborating with so many people here on, these initiatives are going to make a huge difference for patients in Africa, but they're also going to strengthen the data and the approaches that we take globally. And so just want to emphasize the importance of African-led research and working with partners in a true partnership model where they are also determining the direction of training programs, research programs, and also defining the access that they want to achieve for their patients. Thanks very much, Will, and really a pleasure to be here with everyone.
Thank you, Jennifer. And I think you bring back out the win-win. There's the potential benefit for not just Africa or low and middle income countries in India or Southeast Asia, but even the high income countries also win. That's really, really important. And really just want to commend you for the Hypo Africa, which has really become one of the leading clinical trial programs in Sub-Saharan Africa. So, okay, we're going to ask one of our other panelists now, Nusrat Aman, who is one of the key things we've been talking about, we haven't really addressed, is the second part of President Biden's cancer moonshot, which is really for patients who are already having cancer, you know, what is the experience for them? So thinking about even palliative care. So Dr. Nusrat is going to talk to us about the initiatives she's leading on palliative care. Nusrat?
Thank you, Will. Thank you, everyone. I wish I was a doctor. I'm not.
Okay. Yeah. So
just want to start very quickly. So in 2007, my mother was diagnosed with breast cancer. She had a lump in her breast and she went to see a doctor. First, she was given a course of antibiotic for the lump, which had a little bit of secretion. She went to see a gynecologist. And when that didn't work, then her doctor sent her for a biopsy. And she went on her own to the biopsy. And when she was changing and was going to go in for the biopsy, the nurse who was there told her, "Oh, so now you're going to get chemotherapy." So that is how my mother found out about that she probably has cancer. And that's just where I want to start. This is in Bangladesh. And I think that kind of resonates the situation in Bangladesh about how a patient or a family is given the news. So breaking the news about cancer, or the related terms, the scariness of it. And then from that point onward, the journey was, there was not a surgical oncologist who could do the surgery for her because she didn't have access. So she needed to go to India for the surgery. She needed to have chemotherapy and radiotherapy. She had an infection because in India. And then we moved her to Singapore for her radiotherapy. So it was a journey. My mom's fine now. She's living. After that, she also had a uterine cancer episode, but she's fine now. But not all moms in Bangladesh, or all young women in Bangladesh, like the photo that you showed of the Ghanaian girl, they are not as fortunate. So Bangladesh has about 150 oncologists right now for a population of 180 million people. We also have just about 23 pediatric oncologists in Bangladesh. We have about 3 working radiation centers across the country in public hospital facilities. And 2 of our largest divisions don't have any radiation facilities. Dhaka, the National Cancer Institute in Dhaka, I don't know right now whether the radiation machine is working, but it wasn't working last year. From there, I just wanted to give you a little bit of the scenario, what's happening in Bangladesh. In terms of living with cancer, one important thing is pain and symptom management. In one of the largest private hospitals, because we don't have a lot of data from what I got, one of the largest private hospitals in Bangladesh has an annual access to only 10,000 10 milligram pills of opioids, of morphine, oral morphine, 10,000 10 milligrams and 10,000 15 milligrams. So, and this is just in the urban area. If you're outside the city, in the villages where more than 65% of our population live, there's hardly any access to pain medication. So what do we do? How do people in Bangladesh live with cancer? Right now, I think we have probably roughly around 250,000 people who require palliative care in Bangladesh. We have less than 10 palliative medicine specialists in the country. And that includes somebody who's working in the Rohingya camps as well. So what we have done, I represent an organization called Ayat Education, of which I'm the founder. And we started working on this, on working with people in the communities and training them in the communities to sort of help lift the quality of care that people receive. And what we have seen is that when you have such difficult situations, you can you almost try your best to find a little bit of solution with what you have. And one of the things that, after the bad things that I've told you about Bangladesh, one of the things that Bangladesh has, a good thing, is an amazing network of community health workers. We have more than 50,000 community health workers in the government system, and about 100,000 more community health workers who are part of an NGO of civil organizations like ours and nursing colleges and other places. So we're right now working with a few communities in outside Dhaka, where we are training volunteers and the existing community health workers on how to provide palliative care at home in absence of medication. So they go from house to house, and they maintain a database where they just do basic symptom management, like, engaging the families, engaging the community, engaging the youths in the community, helping preventing bed sore, helping the patient and the families understand that in cancer, often more is not always more. You can do less but achieve more, and that dignity and respect are the most important things when a person is towards the end of the journey. We have a nursing college, and in our nursing college, we've learned that our nurses they want to give, they want to work in the community, they want to be there for you, but they often don't receive the training on bedside manner, or they don't receive the training on how to go and help people who need it. So to answer Will's question, or that burning question, I think all the things that each of you talked about is so important. But along with that, I think talking about access to pain medication, talking about leveraging your communities to create that strength, so that the journey, even though it's difficult, it doesn't always it doesn't have to be one of regret. It can be something that, you work towards, you work together, and you walk together. So yes, I mean, Bangladesh I was looking at our stats, and we have about 5.25 physicians for every 10,000 people in Bangladesh, which is the lowest in South Asian country, except for Bhutan. I think Bhutan has a lower number than us. But we also have only 3 nurses for 10,000 people in Bangladesh, which means Bangladesh is one of the very few countries in the world where we have less nurses than doctors. So I think if we are to invest, and if we have a global fund in countries like Bangladesh or other South Asian countries and resource-constrained countries, one is to invest in really dignifying the sector of nursing, so that people understand that being a nurse is as important as being a doctor, because we often don't realize that. And also leveraging the community power that we have, our youth power that we have. Bangladesh has we have more than 51% of our population is below the age of 30. So how can we leverage that? And how can we leverage the strength that the young people bring to bring awareness, to create awareness in the community, so that early interventions and early diagnosis is there to reduce the suffering towards the end. I know, Will, I've taken more than 3 minutes, and I apologize, but just wanted to say a little bit of that. So thank you.
Thank you so much, Nusrat. Yeah, that's really important, the palliative care, and your point about community health workers empowering nurses. And that actually goes to the focus on workforce that we talked about at the beginning. Investing in workforce, that's going to be a really powerful area where I think a global fund can definitely focus. So I'm going to quickly give a chance also to David, who spoke at the beginning. and also Hedy to give 1 to 2 minutes comments on Global Fund for Cancer. Where will be your priority? And I'd like to welcome everybody who is on right now and to post what their thoughts are on the chat, so we can capture that as well. What your focus would be. David?
No, thank you, Will. So let me thank you on behalf of all of us gathered around the table at pulling together a remarkable panel, as you always do. It's fantastic seeing old friends and making new friends. Very brief comments to me, but I think building on what Eduardo said, so I think this new word glocal, start global and go local, is something that we heard it here, invented by Eduardo Casa. And thinking about how we would structure a global cancer fund, I see as being a repository of knowledge. If we look at the discussion that we've had, if we look at the remarkable innovations being carried out by many of our contributors today, there's a lot of implementation knowledge here. Again, Eduardo said it, we have a large enough body of evidence, we have a large enough set of guidelines, but how do we drive these forward? And here we have individual groups, Stephen, our other colleagues who are doing fantastic work. And if we can capture that so that all of us can dip into that repository to learn, to copy, we'd say that copy is a sort of greatest form of, plagiarism is a greatest form of, supporting and recognizing the worth of others. The idea about matched funding, again, back to Eduardo's wise words, that if we ask each government to set up their Cancer Control Committee with representatives, the sort of representatives that you brought together today, Will, from civil society, representing survivors, the finance ministry, health, transport, education, that again, that sense of multidisciplinarity, and that cancer control committee locally prioritizing their own actions, and with match funding coming from the Global Cancer Fund and drawing down some of the practical experiences that we've heard today. For me, I've got a much clearer idea structurally as to how we might move forward. So I found this an invigorating and fantastic meeting. So big thumbs up as always.
Great. Thank you, David. I know, you've been championing this already for a while, the Global Fund. So I think we're reaching a critical stage, where this can actually become a reality. So thank you for all those efforts and those insights. Hedy, are you there?
So I just want to echo what David said. Will, thank you very much for putting this together. I learned a lot, and for that, I'm very grateful to all the speakers. Will, I learned a lot what to do in our commission as well. Just so everybody know, Will is leading the section on IT technology and changing healthcare the way we know it today. So I hope you learned and you listened as well. I'm going to go back to Dr. Eduardo Casa's word. Living in the United States, we always say that all politics is local. And it was actually Tip O'Neill, one of our good House speakers many years ago. So all politics is local. So how would we go about distributing global fund? Number one, you need data. Because we just heard what Bangladesh needs and maybe what Kenya needs are not it's not the same. So data from every country, data. And it's really all about data and not politics. Second, we need government to really understand that cancer is a new pandemic, and they better address, because it's going to really be a catastrophe, a disaster as cancer is moving to younger and younger age, especially in Africa. It's a tremendous economical impact. Maybe they understand money and then have a multidisciplinary groups. I absolutely agree, and Will knows that community healthcare workers are one of our big answers in addition to IT for the future of medicine. So having data, having strategy, making sure government understand and really helping with those resolutions, WHO resolutions, because even if we have all of that, our patients need to be able to afford the diagnostics. We'll go to surgery later on, but it's really important to pass those resolutions and then work with the government so they implement the resolution that has already passed. But most of all, thank you all for this wonderful section, and Will, once again, you simply shine. Thank you.
Thank you so much, Heidi. And we are all looking forward to supporting the World Health Resolution that you're developing. I think, thank you so much for championing that. You know, it's really, really important. And since our time is up, but I would like to encourage that everybody chimes in, you know, post what's on the chat. We are going to make sure that we actually put this together. We also want to thank the organizers of London Global Cancer Week, Susie and Mark, for providing this platform for us to do this. I can promise that next time it will even be much bigger. We know that this intellectual input, this coming together, is really, really important. And to end, I'm going to welcome the person who welcomed at the beginning, Dr. Ahmed, to give a brief, goodbye. 30 seconds, Professor Ahmed.
Yes, 30 seconds. 30 seconds, very quickly. It is very promising and very encouraging, really, initiative. I would like to say just one point. If we just concentrate on fund that will put money on one side, but the money disappears on the other side. So we should consider all the time on what David and what Eduardo said, better value and implementing science. So how we to lower the total cost of treatment. Otherwise, all funds will be disappeared in very expensive things. There are a lot of waste. I give just example today of $3 billion per year for the leftover in vials. This is shocking, but there are many other examples. We see it in our book, as you know, our book together and our courses. So don't put money from one side and then let them leak from other big hole. Better value cancer care for all. Is it possible? Yes, it is possible. Thank you all.
Thank you so much, everyone. And I would just end by saying that some of these conversations should continue. There are many other events on London Global Cancer Week that are going on. So please check out the website and join some of those events. And that this feedback we are getting today, we actually want to bring this back to the White House as well. So thank you all for your contributions. And we look forward to more conversations around this. Have a great week. Thank you.